Let's do Alex.
85-year-old female, mild blurred vision, both eyes. She's not aware of any new problem with her vision. She was in for a checkup with a new doctor since her prior ophthalmologist retired. She's got rheumatoid arthritis. She's on aspirin, levothyroxine, Pepsid, Prolia, Orencia, pre-filled syringe. Her visual acuity in the right eye is 20/80, 20/40 in the left, and her pressures are within normal limits. Via color fundus photo of the right eye, the material is clear. The nerve looks pink, fairly sharp and flat, a little peripapillary atrophy. The vessels are normal caliber. My attention's drawn to the macula where there are some pigment changes. I see both hyperpigmentation and hypopigmentation. This eye is very similar to that eye, except there's a lot, the pigmentation pattern is a little bit different. There's a couple more well-defined dark pigmented spots, and then there's a little bit temporally some areas of hypopigmentation. See an OCT. I presume it's the right eye. The material looks clear, not visualizing the posterior hyaloid membrane. The retinal layers look fairly organized. My attention's drawn to some subfoveal deposits or disruption of the RPE layer. It looks like there's some pigment migration there. Same thing this side.
What do you think the diameter of that is about on the other image?
Go back.
How far across is that about?
That, I don't know, maybe 200 microns.
Yeah, the retina is 250 at the edge of the macula, the peak retina.
Yeah.
The bottom's 250. It's probably a little more.
Maybe 350.
Yeah, probably 350.
And the same thing here, just a little bit more pigment migration into the upper layers in the fovea.
Left eye.
The left eye is the same without those pigment changes. This looks normal. This is the OCTA, showing what looks like neovascularization in the macula.
Can you use some words to describe it rather than just telling me what it is?
A vascular web within the central macula.
So that OCTA was the first visit.
Okay.
So it's 20, this goes 2019, 2020, and 20,
Yeah.
2021.
Those are getting,
Those are
it's
about
getting a little
200.
thinner, and the deposits are getting a little larger. Essentially,
This is the follow-up OCTA.
it's similar. It looks like there's an area of vessels growing into the macula.
And this is recent, I think.
Recently, so now we see, a large subfoveal deposit with hyper and hyporeflective areas, heterogeneous, and disruption of the retinal layers, and it's kind of thinner. The retinal layers are thinning as well.
So that this OCT finding has had a couple names that are attributed to it. I think Rosenfeld's calling it a double layer sign,
Okay,
and that seems to be catching on. The other one was, I like the other one, it's kind of catchy. It was a broad, I can't remember. So something that's important is the diameter. So when you look at it's a PED, right?
Mhm.
So there's a pigment field attachment that's about 300 microns across. So the thing is, when you have a PED 300 microns across like that, what are the odds that it has a blood vessel growth in it? It turns out they're pretty high.
I like broad-based
Yeah.
PEDs.
All right. Just about to talk about the findings like you just mentioned. This is kind of how I tortuous lacy wheel shaped macular lesion in the OCTA. What would you give as your differential?
Oh, we're not doing a fluorescein?
No,
Yeah.
of course.
Okay, differential, just different things that can cause subfoveal deposits or neovascularization of the retina.
Kind of some of the stuff.
Yeah, so you go with the things that can cause deposits and then things that can cause CNV.
So I kind of talk about OCT angiography a little bit because, we haven't really mentioned it a whole lot. It's relatively new. And essentially what it does is it does motion capture of RBCs as they're moving around and then kind of subtracts everything else away. So then that gives you like a 3D view of the retinal and choroidal vasculature. And so like on OCTA, if you have a CNV, it can be like CFAN or coral formed within the outer retina. And then just like the different like type 1, 2, and 3, how they appear on the OCTA. So like type 1 is between RP and Brooks. Type 2 is from the choroid and traverses the RP Brook complex. And then type 3 is like intra and subretinal hemorrhage on the OCTA. They're intraretinal anastomoses originating from deep capillary plexus of the retina. So this patient had something interesting, which was on the OCT, you don't see like intra or subretinal fluid, but on the OCTA, you definitely see neovascularization. So it's a non-exudative neovascular AMD. And this is relatively new, and it's a lot easier to identify with OCTA. So the first few times that this was reported was in postmortem eyes that had AMD, and that was in the 70s, but they didn't really have a good way of identifying it. After ICG was developed, it was, you could sometimes see it as hyperfluorescent plaque with late staining, but then this is, an invasive thing. You're, injecting something into the veins, so it's not as easy to do as regular OCT. So not everybody with, AMD that looks dry on regular OCT is going to get an ICG. Now that there's OCTA, it's a lot easier to identify. And it's important because the non-exudative neovascular portion of AMD, it's a risk factor for developing into exudative disease, but it actually is a little bit of a protective effect against progressing from dry AMD to geographic atrophy. And then with establishing this diagnosis, you can kind of identify which patients with, quote unquote, dry AMD need more frequent monitoring to see if they convert to wet or exudative. And the literature that I was able to find was saying that if you're able to identify this non-exudative neovascular AMD, that you should still wait. You shouldn't give anti-VEGFs right away. You wait until it converts to exudative on OCT, so that there's like, fluid identified on OCT. So that was a pretty quick case.
Yeah, there was a review in Ophthalmology Retina a couple of years ago. About 25% of them convert in about 1 or 2 years.